Our next topic is sleep disorders. Now, when we talk about sleep, it's important to know that there are different stages of sleep. And for USMLE, they will mostly test the different types of waves, what happens during the sleep, and the associated disorders. So let me quickly give a brief summary of the physiology. There's two types of sleep. There's the REM sleep, which means rapid eye movement, and the non-REM sleep. This is non-rapid eye movement sleep. When we think of non-REM sleep, there's three main stages. There's N1, N2, N3. And this has a slow EEG rhythm with high muscle tone. So what happens here is our brain is asleep, but our body is active. Think of it like that. When we pass the sleep latency period, the time that takes for you to fall asleep, you enter into the first stage, that is the N1 stage. Then over time you enter into the N2 stage, and then into the N3 stage. These are deeper forms of sleep. It comes back up again, and then from N1 you may enter into N2 or into REM sleep. This usually takes around 90 minutes for a person to enter into REM sleep. Now, when we talk about N1 sleep, there is a classic EEG finding called Theta Waves. And this is the lighter stage of sleep. And this is when you would suddenly have myoclonic jerks. Now, you might have experienced this while you were sleeping. You had a sudden urge to kick out, and you do that. N2 sleep is associated with K complexes and sleep spindles. And Bruxism, which is the grinding of teeth, occurs in this stage. This is the longest stage of sleep. During a night's sleep, you will be in this state the longest. Next, we have the delta waves. The N3 sleep, which is composed of delta waves. This is deep sleep. This is the sleep which you need to get you back into full energy. And throughout the night, this length decreases and it disappears in the elderly. As you grow older, you don't have this N3, the deep sleep. So that means that causes the elderly to wake up tired. Next, we have the REM sleep. And a person would enter into REM sleep around 90 minutes after they first go to sleep. The EEG resembles an awake state. So there's a lot of beta waves. When you are awake, there's a lot of beta waves. When you are tired, you have slower alpha waves. So this causes this sleep to be called paradoxical sleep. And it is also important to know, during this time, your brain is awake, but your body is paralyzed, except for one organ. Okay, let me come to this. This is when you have increased heart rate and penile tumescence. So there's going to be penile erection. But in general, there is a loss of muscle tone. There's sexual arousal. And on EEG, you can get sawtooth waves. Now, like I said, the person would alternate between awake state, stage 1 of non-REM, then stage 2, stage 3, and they would come back to stage 2, back to stage 1, and the person would wake up, move around in bed, go back to sleep immediately, enter stage 1, stage 2, and gradually throughout the night, the duration of non-REM sleep decreases, and then the REM sleep increases. If this was one entire cycle of sleep, in the early stage, the non-REM stage is more prominent. But as we go into the night or into a longer time period, REM sleep becomes more prominent. And with age, the total sleep time decreases. Now, there are some neurotransmitters associated with sleep, and there's a famous mnemonic called SANDMAN. SAND stands for the neurotransmitters. S for serotonin, A for acetylcholine, N for norepinephrine, and D for dopamine. Serotonin initiates sleep. Acetylcholine produces REM, so they will increase the sleep stages. Norepinephrine will be decreased during sleep, and this is related to REM sleep. Dopamine causes arousal and wakefulness, the penile erection, and it will make you more wakeful. So patients who are on antidopamine drugs such as haloperidol will sleep more, and people on bromocriptine will sleep less due to high dopamine. Alcohol intoxication will suppress REM, and withdrawal symptoms, as we talked about, it will always be the opposite. Will cause an REM rebound, in which you get longer REM sleep. There are some very important associations of the different stages of sleep, and this is something you need to memorize for USMLE, especially for step 1. N1 stage is associated with obstructive sleep apnea. This is when the patient has difficulty breathing and there's a lot of snoring involved, and this is done in the respiratory chapters. N3 is associated with sleepwalking, night terrors, and bedwetting, and something called sleep inertia. So what happens if you wake during N3 state? You have no concentration. You are very groggy. You don't have any sort of energy. You are just sleepy. Sleepwalking is associated with N3. So what this means is the person, even though the person is walking, is in deep sleep. And night terrors, we will talk about it in a while. Bedwetting, we will talk in child psychiatry. REM is associated with major depressive disorders and neurocognitive disorders. In major depressive disorders, you get decreased REM latency. That means you enter REM state faster. So typically it's 90 minutes, but the time to enter will be less than that, let's say 60 minutes. There's going to be an increased REM density. You will be more often in REM. Increased REM duration. You stay longer in REM. And multiple awakenings and early morning awakening. So you go to sleep at, let's say, 9 p.m. or even if you go to sleep at 12 a.m., you will wake at 4 a.m. Next, sleep deprivation. The area of the brain most affected by sleep deprivation is our cerebral cortex. And due to cortisol changes, there's going to be changes in the lymphocyte levels. There's going to be a decrease. The blood pressure will increase. Amygdala activation and negative mood rises. So when the amygdala is going to be activated, a person would be more prone to anger. And the ability for glucose tolerance and prefrontal cortical activity decreases. You can't think properly. If a person sleeps only 5 hours of sleep every day, they will function like a drunk person. And REM sleep is very important for learning. So if a person does not have REM sleep, that means the later part of the night, that means they will have difficulties in learning. Also, this fact that human growth hormone increases during sleep is very important for a growing child. When we talk about melatonin, it relates to sleepiness. So we give this as a drug to treat difficulty in sleeping, insomnia disorders. And this is produced by the pineal gland, and directly from the retina of the eyes. And this is sensitive to light. So there is a condition we already discussed called seasonal affective disorder, in which nightfall would occur early during winter. So these patients would go into a depressive state during this time period. And if it occurs more than two or more years, this is diagnosed as seasonal affective disorder. The treatment is bright light therapy. You make sure that the patient stays under bright light. Now, the sleep disorders that we will talk about include insomnia disorders. This is difficulty falling asleep. Hypersomnolence disorders, where they would sleep a lot. Narcolepsy, sleep terrors, and nightmares. Let's go into detail of these now. Before we go into insomnia, there are some pharmacological treatments, such as short-acting benzodiazepines, such as temazepam. These can be given to induce a person to go to sleep. But the problem is, diazepams will cause the person to be groggy the next day. Then the Z drugs, solpidem, zopiclone, these drugs were created. These are also benzodiazepines. They have a lesser side effects of being groggy the next day, but then there was a risk of addiction. So they had to create new drugs. We will go into those in a while. Then melatonin, antihistamines are also prescribed. Now, what is insomnia? This is a disorder characterized by difficulty initiating or maintaining sleep. And this affects a person's daily productivity. If you haven't slept, it's hard for you to be productive. Causes include life stresses such as exams, excitement, drugs, changing environments, then anxiety, depression, bipolar disorders, physical illnesses, which makes it hard for you to fall asleep due to pain, obstructive sleep apnea, and substance abuse. And the treatment for insomnia, the first line treatment is sleep hygiene. Now, if there's some underlying cause, you need to treat that. But the first line treatment before we try any drugs is sleep hygiene. There are different things that we need to consider in sleep hygiene. Like you need to reduce the light, reduce noise, regular exercises, and avoid meals during night time. You need to finish your dinner by, let's say, 8 p.m. Avoid stimulants such as coffee. Then you ask the person not to sleep during the day. Do not have naps during the day. And then this is also a very important thing, which is called stimulus control. This is when you avoid doing other things in bed. So before you go to sleep, you may have a lot of stimuli, such as your mobile phone. Then you watch movies in bed. All of these stimuli will make sure that you don't fall asleep. It makes sure your brain is active. And therefore, we need to ask the patient to not use these things while going to bed. We can go for pharmacotherapy, but then again, I need to repeat, sleep hygiene is the first line treatment. They have the Z drugs, and because of their risk of addiction, we do not prescribe them for a long time. The problem with these drugs is when the person takes the drugs, he will fall asleep faster. But the moment the person stops taking the drug, they will go back to the way it was. So we needed to make a drug which is non-addicting. And the drug was Ramelton. This is what we use to treat insomnia disorders. And this acts on melatonin and is non-addicting. Again, benzodiazepines, tricyclics, all of these will make the person, including the first generation antihistamines, make the person feel groggy the next day. Next, we have some parasomnia disorders. The first one is nightmares. And we need to be able to differentiate between nightmares and sleep terrors, especially for USMLE Step 2. One of the key features of nightmares is the child will remember. The child will come running to you saying that he had a nightmare. He saw monsters chasing after him. And and if there is a situation where the content is the same, you need to look for some sort of a stressor, such as the teacher shouting at the child. And again, nightmares occur during REM stages. This is not treated. There's no treatment for this. You don't go to give them drugs. But let's talk about sleep terrors. This occurs earlier than nightmares. And usually the mother will describe it, not the child. They would run to find the child screaming, seated in bed, disoriented, would stare at the mother and just fall back asleep. The child will not remember what happened. And this is more common in boys, and this occurs during deep sleep stages. Treatment is not needed. Again, treatment is not needed. You need to reassure the patient. But if it is needed, consider benzodiazepines. Now, sleep talking, it's common in children and it can occur in all stages of sleep. Usually they would utter a few words and they may be related to night terrors and sleepwalking. There's no treatment for this, so be careful what you say. I know you can't control it. Sleepwalking, somnambulism. This occurs during stage 3 and 4. And they would wake up tired and confused. Next, we have narcolepsy. We have a 25-year-old man who is hospitalized after he crashed his car into a tree. When questioned, he does not remember why the accident happened. This was his 4th time in the last month. His family reports occasions when he would fall asleep in the middle of conversations. This is a typical case of narcolepsy. This is characterized by excessive daytime sleepiness with recurrent episodes of overwhelming sleepiness 3 or more times per week for the last 3 months. This is the diagnostic criteria. And instead of the normal 90 minutes it takes for you to go into the REM state, these patients will enter into REM state within 10 minutes. And this fact is also very important. This needs to be identified in a case. Upon waking, the patient feels well rested. Now, there is a substance which will be tested, especially in USMLE Step 1, called orexin or hypocretin 1. This is produced in the lateral hypothalamus and is related to narcolepsy. This substance can be tested in the CSF. So in a test question, they would ask something about testing orexin in the CSF. There is something called cataplexy. This is when the person suddenly loses muscle tone. And when you do a sleep study, a polysomnograph, you can confirm the diagnosis. So when a person is falling asleep and is excessively tired, there's obviously going to be low productivity. And accidents may occur if they're driving. And very importantly, you need to know these 4 associations. This is associated with something called hypnagogic, that is just before going to sleep, or hypnopompic, just before awakening hallucinations. This is the more common one. They would have hallucinations. Then there would be sleep paralysis. And Most importantly, there's cataplexy. This is when the person loses muscle tone following some sort of an emotional stimulus. If they are in a fight or if there's laughter against them, that would cause them to lose muscle tone. And then there's sleep paralysis. The treatment again is good sleep hygiene. So you force naps at regular times of the day, and there should be a regular sleep schedule. If there's some underlying cause, treat that. And then you can give these patients stimulants such as amphetamines, modafinil, methylphenidate, coffee, and something called GHB. And remember this, modafinil is preferred over the others because it's a non-stimulant stimulant. It's not going to cause the side effects of amphetamines such as increased heart rate, loss of appetite, all of these. And if cataplexy is present, you can use antidepressants such as TCS and SSRIs. We have a 9-year-old girl who's brought to the office by her mother who's concerned about her behavior. Over the past month, the child has awakened almost every night, comes into the parents' room and insists on sleeping the remainder of the night in their bed. The girl wakes up abruptly in panicky sweat, crying and screaming, "I'm being chased by monsters." Is this a nightmare or a sleep terror? This is a nightmare. She breathes rapidly and shakes but is able to be calmed down after being consoled by her parents. She is basically awake now and she falls asleep again. She enjoys school and has several good friends. Examination shows no abnormalities. Which of the following is the most likely diagnosis? This is a nightmare disorder. Which of the following is the best next step in the management of these patients? Reassure the patient. There's no treatment. You don't give them drugs for nightmares. Next, we have a 4-year-old girl who's brought to the office as a patient has awakened 1 or 2 times a month over the past few months shortly after going to sleep. When her parents go into the room during these episodes, she's short of breath, crying and sweating, and her face is flushed. The patient appears frightened, does not respond to her parents' attempts at comforting her, and continues to cry. She eventually goes back to sleep on her own and does not recall the incident the next morning. Now, what is this? It has to be a sleep terror. The patient is in deep sleep, N3 and 4, and the patient does not recall anything that has happened. She's not actually awake. A complete physical examination is unremarkable. Which of the following is the next best step in the management of this patient? Again, it's reassurance, and the diagnosis here is a sleep terror. Next, we have a 20-year-old college student who comes to the office due to irregular sleep for the past 2 months. The patient says, "College has been stressful, and I have been feeling more fatigued since my girlfriend broke up with me last month. He often feels sleepy during the day and sometimes falls asleep unintentionally during classes." The patient goes to bed at 1 a.m. and awakens at 9 a.m., which is normal for a college student. After classes, he avoids socializing and frequently returns to his dorm to nap. The patient also describes, "Weird things happen as I fall asleep, like I hear whispers and see colorful animals, hallucinations." Then there's excess sleepiness. He describes another unusual experience when he suddenly felt weak in his face and knees following a stressor, an upsetting phone call with his girlfriend. Cataplexy. He has a history of depression and that responded to psychotherapy. Physical examination is normal. Which of the following is the most likely diagnosis for this patient? The answer is narcolepsy. What is the best next step in the management of this patient? The answer is sleep hygiene.